Hey everyone, it's Dr. Bauer from IVF MD. So we are getting ready to, we are live for our fertility Q&A with Dr. Ferraduro from Florida. We're going to add her in right now. I hope everyone is doing great. We'll see if she pops up soon. Let's see. Hi.
Hello.
How are you?
I'm good. How are you?
Excellent, excellent. Another Wednesday night.
Yay.
Perfect. Well, so we have some good questions to go over so far. Just for introduction's sake, do we want to, just in case we have some new followers, to introduce ourselves?
Sure. Go ahead, yes.
All right, good. So like I said, I'm Dr. Jessica Bauer of IVF MD. I see patients in multiple offices, including the Jupiter office, the Boca office, the Vieira office, and also as well virtually. I've passion for fertility preservation and infertility in general, and just excited to be here always with Dr. Duro.
Yes, thanks so much for doing this as well. I really think that this makes so much of a difference when, you know, it's just such a stress-invoking whole procedure when you're trying to wait for answers. So I hope that we can provide those answers today, or some of them at least. And for those of you who don't know me, my name is Dr. Ferraduro. I'm a licensed reproductive acupuncturist, and I practice in Hialeah Gardens. I've been practicing for about 20 years now, hard to believe.
Wow.
A long time, half my life now. So we've been, you know, basically just very fortunate to work with fertility patients since 2004, I believe, yeah. So working with your practice for many years, just seeing all the great progress that patients have had, and seeing many, you know, generations now. Like, some of our patients are actually in kind of like perimenopause, so, you know, we see they're teenagers now, so I'm like, wow, for real. But
makes you feel old, right?
Yeah, it's like in a happy way, you know, it's good.
Yeah.
So yeah, we're happy to be here, and we definitely have some good questions tonight, so
Yes.
We'll be getting to them as well.
Absolutely. Perfect. Yeah. So, so I have questions. Sorry, they're on my computer over to my left over here, so you'll see me look at those. But the first question that we have is it recommended not to have sex while on IVF meds? So my party line, the short answer is that I do advise people not to have intercourse during stimulation. And that's for a couple of reasons. I would say the first reason is that, you know, whenever, because we are stimulating your ovaries with very, you know, more potent medications and generating multiple eggs, you know, if you have sex and there's within, you know, 72 hours potentially of, you know, of an egg retrieval, there's a possibility that you could get pregnant. And certainly, obviously we know that is the ultimate goal, but we are going through this, a lot of people are, you know, going through the process to do genetic testing or something like that. And so I usually, you know, to be true to the process, ask people not to do that. And then the other reason is more of like a safety perspective. So your ovaries get pretty enlarged when you are doing ovarian stimulation. And because of that, the ovaries become heavier than usual and also much larger. And they're at increased risk for twisting on themselves, which of course can be pretty dangerous. And if that were to, you know, any sort of activity, whether it be sexual or otherwise, can increase the risk of that happening. And in general, also what I tell patients is that, especially like towards the middle and end of stimulation, when you may be experiencing some like lower abdominal and pelvic bloating, and whatnot. Sorry, my puppy just opened the door with her nose and came in.
Oh my gosh, you have a puppy too. I'm outside, so my puppy isn't gonna bark.
This is mine. This is Penelope.
Oh my gosh. Oh my God, what's her name?
This is Penelope.
Penelope. Oh, very old and wise eyes, but young soul.
Yes. Yeah. Anyway, sorry. So I usually tell patients that they very often because you're experiencing a little bit of bloating and maybe some discomfort when the ovaries become large, you probably are not going to be, terribly interested in intercourse, but, and maybe you are, and that's fine, but we usually advise that you not do it. So
Yeah.
that was a very long.
And first trimester too, right? Sometimes, like, or how far into the first trimester would you say?
So that every doctor will probably give you a different answer. When it comes to IVF and individuals that have obviously worked very hard for these beloved pregnancies, I'm a little superstitious and overly cautious. So I, of course, ask patients to abstain from intercourse from the time of transfer, at the very least until their first ultrasound. And then usually if things are looking good, I ask them to wait to the next ultrasound, which is usually a week or two later, to make sure that the pregnancy has grown appropriately, that the heartbeat still looks great. And then at that point, you certainly can, have intercourse. There are certain patients that certainly should not, regardless, and you should, talk to your doctor about that. But the thing about it is that you can, any sort of sexual activity can potentially cause, a little bit of irritation in the vagina and the cervix and some bleeding, and bleeding in early part of pregnancy can be very scary. And it's not always bad, but it can be very common. And I just think it causes more anxiety for patients, especially because they're, day by day, just trying to take it day by day, excited by their pregnancy and whatnot. So certainly not, you don't have to abstain from sex through the entire first trimester. I certainly like in my IVF patients to make sure that we have a viable intrauterine pregnancy and whatnot. So that's my party line. Like I said, every doctor will probably say different things, but that's sort of my take on it. I just think it's better to be a little more conservative in those scenarios.
Sure. We do have a question that popped up here about a chemical miscarriage or chemical pregnancy. Do you think it's best to go right ahead with another transfer or wait?
So I would, chemical pregnancies are super hard after transfer. You get all, super excited because you see that positive HCG, and then sometimes it might be a little lower than expected, and then it can fall. And that's where it becomes, very stressful and super upsetting. Generally, as long as your HCG level goes back down to 0, you can generally proceed with another embryo transfer or preparation for another embryo transfer relatively soon. There's no need necessarily to wait a very long time. Some doctors, depending on the length of time from which you recently had a uterine cavity evaluation, like something like a saline infusion sonogram, which really identifies if there's anything inside of the uterus that could prevent pregnancy or cause a miscarriage. Some doctors like to do that prior to another embryo transfer. I generally fall into that category because regardless of whether it's a biochemical or a miscarriage, having a pregnancy of any kind inside of your uterus could potentially change something inside there, and you certainly would want to correct that before moving forward with another embryo transfer.
Okay.
Yeah.
Okay. While we're on IVF questions, we have
a
question from Eva just got stimulated, got 10 out of 5, got inseminated, but only 4 got naturally fertilized. So does that mean that I got 4 total embryos? I still have to wait to Monday to find out about their biopsy. Does that mean they're all good? So 4 embryos.
I just got stimulated, got 10 out, 5 got inseminated. I assume that means fertilized. But only 4 got naturally fertilized. Does this mean that I've got 4 total? So as of right now, so it depends on what day it is. So as of right now, yes, you do have 4 embryos, but what you need to see, after the eggs are retrieved, we fertilize them with the sperm, and then you see how many of them make embryos, and then you put them in the incubator, and then you leave them until you look around day 5 when you're able to do the embryo biopsy. and you see how many of those embryos that successfully fertilized made it to the point where they're able to get biopsied, because usually not all of them do. And that's a normal phenomenon. And so if you're waiting until Monday to see how many of them were biopsied, that number, best case scenario, could be 4, but it might be less than that.
Yeah, completely.
It gets confusing.
Yeah, I know, and we just need one good one, you know.
It's true. It's true. You know, you just need one, and it's very. I think one thing that I always try to stress to patients, and this is really why I really stress education through this process, because you know it's of course one thing to blindly trust your doctor, which hey, that's fine by me, but I want to be able to educate you so that you understand what's going on. And I always make sure that I sit down and really take patients through what the process will look like, and understanding that there is loss at every point when you're undergoing IVF. So not every follicle that grows will even have an egg in it, right? Not every egg that you retrieve will be mature. Not every mature egg will fertilize. Not every fertilized embryo will grow appropriately. So there's drop off at every point, and that's a normal thing. And sometimes the drop off can be pretty drastic, which is scary to patients. But in some scenarios, that's a normal phenomenon.
Yeah, definitely increases with age as we get, you know, to that point. I think, you know, also just having 1 or 2 embryos, some people think that's, you know, that did not meet their expectations. But I think that in many cases, that's a blessing. Like if you can get through a whole cycle and have a really good quality embryo that's biopsied and everything's genetically good, I mean, I think that's a success, you know. So
yeah, no, 100%. I couldn't agree more.
Yes.
Yeah.
We have a few more questions, then we'll get to our previously asked questions. If
okay.
Do that, yeah.
No, it's hard to keep up with these. Let's see.
Yeah, I mean, there is a transfer question, so I'm thinking we're trying to answer the IVF questions first here tonight a little bit, but since we are having so much of them on our chat, but so someone's asking, do you have to ovulate first before having an embryo transfer?
So, so you don't have to ovulate per se, meaning releasing your egg. In fact, in a medicated frozen embryo transfer cycle, we prevent you from ovulating, and instead what we do is we mimic ovulation, because what it is about ovulation or releasing the egg that allows you to get pregnant is first an exposure to estrogen, and then once you ovulate, an exposure to progesterone. Progesterone, the hormone, if you break down the hormone, it's progestation, right? So progesterone, which supports the pregnancy, and you need a certain amount of exposure to progesterone, whether it be from ovulation if you're just having sex on your own, or if it be through exposure to progesterone, whether they be progesterone and oil injections or suppositories, a certain number of days in general before the embryo reaches the uterine cavity. So so you don't have to ovulate per se, you have to have exposure to progesterone before you do an embryo transfer.
Yeah, and some people are trying naturally, you know, to like natural cycles as well.
Yeah, there are some people that do natural cycle to prepare for an embryo transfer, and in that regard, sometimes we do watch your follicle grow, and when it gets to a certain point, we trigger you to thus trigger the ovulation and thus begin the exposure of the uterine lining to progesterone, which is critical to ensuring that the embryo implants. So that's also a possibility. Not done as much because it's a little more difficult to plan out appropriately, but certainly an option.
Yeah, I just actually had a transfer this week for somebody who did a natural embryo transfer, so it was good. Cool. Yeah.
No, it's definitely, it can be the right option for some patients. It's not, you know us doctors, we like to be in control. So it's not always our first option, but in some patients it really is the right choice to do, you know, a natural cycle FET. And I always recommend, you know, acupuncture you know, it's not, people are like, oh, I do the acupuncture before and after the transfer. And it's not just about that. I think I had this question today from a patient actually. And I was like, you need to be doing acupuncture regularly, well in advance of a transfer, in order to really get the benefits of it in terms of increasing blood flow, with the idea of really healthy and thick uterine lining. And so being consistent is really important with that, and making sure that you're doing it leading up to the transfer, not just directly before and directly after.
Definitely. And I realized that some people don't realize that they're stressed as well. So
Yeah,
we definitely have seen, you know, and I think another report just came out about the effect of stress on fertility with COVID. So that actually sent that report around, because I thought, you know, finally someone's putting it all together, and they're seeing the effects of men as well, you know, on male fertility too.
Yeah.
So we encourage the partners to come in. We try to get them in.
Yeah, I know. They're tough.
It's so hard to get them in, but like once they do come in, they're just like, I needed this. I didn't know I needed this, but I need this, you know. So, so it makes a difference. Even in the sperm count, sometimes it can really go up and down depending on your stress or illness, fever, of course, all those things similar. So, and there's a COVID vaccine question here. So, because I was like, wow, we haven't had him in a few weeks now.
No, I feel like there was one time where literally all we did was answer COVID-19 questions.
Yeah.
And then it hasn't come up again.
Yeah, it hasn't been lately, but we do have, this is a good question about, you know, do you recommend the vaccine 1 month before your frozen embryo transfer? Like, what is your time? I know you've said it before, where you want to have good, you know, like amount of time.
I think, like I said, I think with, this is an evolving process, an evolving scenario where, you know, you could ask another doctor and they might give you a different answer. My opinion, based on what we have seen and like the data that has come out thus far, which it's a really important to understand that it has not been a significant amount of data, not the amount of data that we usually generally change our practice based on, but because, you know, obviously a pandemic is a very unusual and scenario where everyone is just trying to do the very best. You know, I think the way that I explain it to patients is that the way that the COVID vaccine works is that it revs up your immune system. It revs up inflammation within your body in order to help your immune system generate those protective antibodies. And that's the way that it's supposed to work, and that's normal. When we are talking about a process as delicate as a frozen embryo transfer, there is, you know, sort of emerging data to suggest that you should potentially wait anywhere from 1 to as many as 3 months after, if you get a 2-dose vaccine, after the second vaccine, before doing an embryo transfer, very simply so that there's no chance that any underlying sort of inflammation or activation of your immune system might compromise the embryo transfer. And, you know, that makes sense from a physiology standpoint. There's just not a ton of data. I'm sure that there are women that have gotten the vaccine and then a month later had a successful embryo transfer, but I'm sure that there are cases where that is not the case. So, you know, it depends. If someone is fortunate enough and blessed enough to have 10 embryos and they say, listen, we want to give this a try, and we want to try, and you're okay sacrificing an embryo, then do it. But if you have 1 embryo, I would wait. I would wait 2 or 3 months and make sure that you can get your body back to equilibrium. And you know, the vaccine, you know, at many people after the second dose, it can take a toll. You feel pretty crummy for a little while. And you don't want to have that, you know, be a confounding factor in your, you never want to look back and say, it didn't work. Should I have waited? I don't know. That's sort of my opinion about that. Yeah.
I agree. And I'm concerned about Tylenol use, honestly. If you have a fever, that's another issue too. So the fever's bad. Tylenol, not good. They actually called it an endocrine disruptor. So this is very interesting research that's come out. And I really try to like caution our pregnant patients too. Like, you know, there is some more research. Please talk to your gynecologist. I'm not sure if this is going to be recommended for you. Acetaminophen is on that list. Ibuprofen, definitely not during pregnancy. So if you have, you know, if you're vaccinated, you've got a fever, which a lot of people do get, which is normal, right, with that vaccine reaction. We had a patient take Tylenol for 3 days while stimulating. And I think this was not good, you know.
Yeah.
So it didn't turn out well for the stimulation sometimes. So I think it's a problem with, you know, with during trying to get pregnant, and then also you know, during an IVF cycle. So yeah, definitely space it out. And the booster shot, I had a few patients be like, okay, this one really kicked my butt.
Oh, really? Yeah. I've heard mixed. I just like with the regular, I've heard people that are like, I was laid out, and other people are
Yeah.
like, oh, cool. You know, I think
Yeah.
it's very variable. And you just want to take that chance, you know, with something that you've worked so hard for when it comes to an embryo transfer. You know, you deserve to give yourself the very best shot. And of course, I support vaccination, and you certainly should do it. And but I think, you know, you have to look at the bigger picture, you know, for sure.
Yeah. So, yeah, well, hey, actually, you know, we got to jump into our questions we have because everyone who submitted questions before, they're very thoughtful in getting those questions to us. So I want to make sure we get to those, just a few of them, and then we'll jump back in the chat too. So you guys can keep submitting your questions because we're here for you tonight.
Yes.
But we have a question about, well, another IVF question, because I don't think we got to that one, about Clomid and Gonal-F treatment for IVF if the body rejected Menopur. I guess this is a really specific question about, you know.
That is definitely a specific question. I think, I assume what this individual is talking about is sometimes when you combine the use of an oral medication as well as injectable medication, we refer to it sort of as a mini stimulation. I don't know what they mean by rejected Menopur. If they, my suspicion potentially is that this individual probably has diminished ovarian reserve, which is, you know, low ovarian reserve. And oftentimes in DOR, or diminished ovarian reserve, sometimes we use Menopur in isolation to try to stimulate the ovaries. And maybe by rejected, they mean that they didn't respond, which is not always the best sign, but I think it is reasonable if you did not respond favorably to Menopur, to giving something like a mini stimulation a try. If you are able to, mini stimulations often do quite well in women that have DOR. And so I think you should, of course, talk it over with your doctor. And I don't know the specifics of your case, but I think it's reasonable to try.
Okay, and then another, wow, okay, someone looks like maybe they're estrogen priming. This question is about estrase.
I think this is
day 15, or they're preparing for
I think they're preparing for an FET.
Okay.
Yeah, so they're day 15 on 6 milligrams of estrase, a 5.4 lining, 203 level of estradiol. Other than acupuncture, what else can I do to help the lining? 5.4 is not great, I'm sure, as you are hearing from your doctors, because they're concerned. In preparation for FET, there are lots of different ways to administer estrogen, and for some individuals, some routes work better than others. So estrase, it sounds like potentially this person is taking it orally. Okay. One thing that I like to do is use estrogen patches. I think that it provides a more steady state of the hormone in your body compared to when you are ingesting it and your body has to digest it and metabolize it and all of that kind of stuff. So sometimes I even use a combination of patches and pills. The other thing, other than, of course, acupuncture, which hopefully, as we mentioned before, was being done, you know, well in advance of this preparation, but sometimes, as I mentioned, changing the route of administration, sometimes putting the estrase tablets vaginally instead of taking them orally, so that they have closer proximity to the lining of the uterus, might be something that you try. There actually is, you're inserting something vaginally and actually taking it orally, you tend to have a similar absorption. And so, but sometimes there is some thought that potentially if you're putting it closer to the source or where you need it, that it might benefit things. You can always increase the amount of estrase that you are on. That does seem like it seems like a dose of someone who maybe they were monitoring a lining and it wasn't quite where it needed to be. But also your estrogen level of 203 is around where you want it to be. You don't want it to get too high, because actually having it be too high can have a negative impact on the effect of, or the success of the embryo transfer. So it's a tough question to answer. Again, with a lot of these questions, it's hard for me to answer without knowing like more history and stuff like that. But maybe consider adding, estrogen patches. But again, you need to just speak with your doctor because you need to be mindful of how that estrogen level is increasing.
Yeah, and another question was, could it be too thick? Could the lining be too thick? So I guess since we're talking about lining, 12 millimeters, that doesn't sound
12 is definitely not too thick. I'd be very happy with 12. There are some individuals that say that no such thing as too thick. And there are some people that start to get a little squirrely, like after 15 or 16 millimeters. The data, at least from my recollection of reviewing it, is, maybe after 15 or 16, you may reconsider trying a lower dose protocol if you have someone that's really an ambitious over responder. But 12 is certainly great. The ideal is, at least between 7 and 8. There's actually some recent data to suggest, we used to always hammer home that 8 millimeters is where you want to be. And, there is actually some data that potentially the thickness is not as important as sort of the architecture of the lining, where you have a trilaminar appearance. So, the jury's sort of still out on that. But 12, I would be very happy with.
Yeah. Awesome.
Yeah.
So we are getting lots of questions also in the chat. So we'll hop back in the chat for a moment and then we'll
okay.
Because I was kind of like, I was losing my place. Okay, here we are. Okay, so about vitamin D levels, 84 too high, you think? Or how do you think? Or she's taking 5?
Is that 80? I mean, 84 is certainly enough. I don't think it's too high. Should I decrease my vitamin? I currently take 5,000 IU. I'd probably either do one of two things. Decrease your dose by half, because you certainly, 84 is a great number, or just keep your 5,000, but maybe take it every other day or every third day, just to maintain your level.
And I was going to mention that MDs sometimes get a lot of flack because, they don't have nutritional training, or that's really, but you do. I mean, you have a nutritional background as well. So
I do.
That, that's really nice that you can also let patients know about supplements and things like that as well. And
absolutely. Yeah, no, it's super, the quality of the supplements that you're taking is super, super important. I tell my patients I'm a total supplement and vitamin snob, that I really like to make sure that what you're taking and what's written on the bottle is actually what you're taking, and that there are no negative effects on that. And it's just, the vitamin and supplement world is a crazy world that is, as many people know, not regulated by the FDA. So we have at IVFMD, we've sort of curated a list of, with the help of Marta, our metabolic and lifestyle expert, to really curate a list of really trustworthy and high quality supplements that we know, because at the end of the day, we just want our patients to be healthy and successful, and that the kind of supplements that you're taking can really make a difference. So make sure you always tell your doctor about any supplements that you're taking, because you never know if it could be, causing a problem. But yeah, vitamin D is a good one. Make sure your doctor's always checking vitamin D. Oh no. Let's see. It seems we lost Dr. Duro. We can hopefully get her back. Let's see. Anyway, there we go. Okay. Oh, she's still here. Oh, there you are.
Sorry, I popped out. I don't know what happened.
No, it's all good. It's all good. I was just like, oh God, what do I do?
I know. I guess this is an experiment. I'm outdoors, so that.
Okay. Okay. Sometimes some spotty Wi-Fi, but yeah, all good. Perfect. Let's see.
Fragmented embryos. That was another question we had.
Yeah. So fragmented embryos are, embryos should not be fragmented. I should start out by saying so, and they can be an indicator of poor quality embryos, and whether that poor quality is coming from an egg source or a sperm source it's very hard for me to know, number one, without knowing your history, number two, without speaking with the embryologist who did your case, who actually had eyes on and hands on your eggs and sperm, because sometimes it can be, you know, I've had cases of, you know, fragmented embryos, and I have them look back and they say, you know, Dr. Bauer, it looks like when you retrieve these eggs, they also were highly fragmented and dark, and it looks like it's really an egg origin. Or they say, you know, the sample that we got, for whatever reason was, you know, was not a good sample from a sperm perspective. And so it's a tough question to answer without, again, having more information, but I would encourage the person who had the fragmented embryos to speak with their provider about more details about their specific case, so that they can understand more about the source of where the issue is coming from, so that they can address that.
Okay, very good. And let's see, we have a question about progesterone suppository as well.
Okay.
A 200 milligram 3D progesterone suppository dose sounds sufficient for a frozen transfer protocol.
So there was actually a recent paper, I think it was in Fertility and Sterility, which is the major medical journal from the American Society for Reproductive Medicine. And they actually confirmed that the use of progesterone in oil, which is, you know, intramuscular injections of progesterone, is actually associated with higher rates of pregnancy and live birth compared to the use of suppositories. And it's sort of an older medication. It's how, you know, they used to do things back in the day. And so I always use progesterone and oil. Sometimes I will actually use a combination of the two. But you know, I think if your doctor feels comfortable with you using just suppositories, and they feel as though you're responding appropriately and that your progesterone levels are, you know, appropriate, that's okay. The gold standard from my perspective is progesterone and oil. So.
Yeah. We do unfortunately have some miscarriage comments as well. I just want to say we're both, like, I know we talked about this, but miscarriage like tears our heart out every time we see it.
Yeah.
And I have a question about, you know, that someone had a chemical miscarriage last week and just stopped acupuncture. When should I go back? And we support our patients through miscarriages as well. We don't stop treating you just because, you know, it did not work out. I think it is incredibly important. There's actually protocols in Chinese medicine to work with the body to help heal after a miscarriage, to help the cycle along and that sort of thing. And if you do have a surgical procedure like a DNC, we can actually work with you also during that time. So, I mean, as long as you're okay coming in and feeling up for it, definitely we encourage it. And you know, and I think a lot of times there's just so much emotion around that. It's hard to know when you're okay. You don't really know. I feel like you're ready when you know you're ready, and you can go back and continue to try. But until then, we do a lot of emotional support and do a lot of acupuncture, massage, and self-care for sure. So
I could use some of that.
Yeah.
But yeah, no, I echo, you know, what Dr. Duro was saying. It's important to, you know, especially when you're going through emotional and stressful times, to lean on the things that can help you manage the stress, and whether it's acupuncture, massage, or whatever. It's really, really important. It'll help you get back on your feet faster and be able to move forward. Yeah, for sure.
Another miscarriage question, unfortunately, is of a high-grade PGS normal embryo. That's the most frustrating thing when you know, have a perfect textbook embryo, no DNA fragmentation, but it just doesn't take. Like, how often do you see that happen in your experience? You know,
not too often, but it's really important to understand that IVF is not a perfect process. You know, transfer of even a PGT, a normal embryo, you know, is about a 65% pregnancy rate or higher, depending, you know, depending, but that's not 100%. And very sadly, either it doesn't take, or you can get pregnant and then it can miscarry. You know, every individual has a background risk of miscarriage, no matter how you got pregnant or with what quality embryo. There's a background risk, and in general, that risk increases with age. You know, there can be other factors related to it. It's just so hard. There's because it's a roller coaster ride of emotions. You know, it's very hard to watch as a you know, and to give the news of that as a doctor of a patient who has again worked so hard and has been so diligent to be her best self, you know, in preparation for an embryo transfer. So you know, just know that it's almost certainly nothing that you did. It just is a you know, a natural phenomenon that can occur, unfortunately.
Definitely. And you know, and I hope you have still hope that, you know, that definitely you can keep trying if that's what you feel, you know, you can do, and
Yeah.
you know, we're here to support you as well.
Of course.
Whatever you're seeing, you know, just know that we've seen many cases where it didn't stick. Maybe it does look perfect, but the next one also was the one that did stick. So, you know, it's just we wish we had a crystal ball and we could, you know, see.
Oh,
it.
I wish.
Yeah, we would love to have that. And then there is a question about embryo arrest at the morula stage. What needs to be checked in egg and sperm? Do you notice like that when and for people that don't know what stage that's in, like what day is that?
Yeah, so the morula stage is generally around like the third day, and leading up to the third day, and sometimes, not always. Again, I encourage these people who are asking these questions to, of course, speak with their doctor, because every case is different. But in general, you know, if you see complete arrest, you know, at the morula stage, occasionally it can be more of a male factor than an egg factor. But I have also seen just pure, you know, sort of aneuploidy or abnormal chromosomes or an abnormal fertilization causing a morula arrest, or an early arrest. And so I would again encourage, but then to be honest, I've also seen, you know, poor egg quality do that as well. You know, and again, just to reiterate, there's going to be a background arrest of embryos no matter who you are, right? No matter how great your embryos and how great your eggs and sperm are, there's always going to be some that aren't going to make it. That's just the way that reproduction works, which is pretty inefficient. It's any wonder that all of us are here. So, in my opinion,
yeah,
it's kind of crazy. But yeah, I would ask your doctor about the specifics of your case, and again, getting some information through your doctor from the embryologist can shed some light onto the scenario as well.
And maybe you never get that answer, but maybe it's not a bad idea to have, you know, the partner take vitamins as well. I mean, it's kind of like insurance, you know.
Absolutely. Yeah. No. Absolutely. You know, I think one of the principles that is super important that, you know, that Dr. Durr and I often touch on when we do these, you know, Q&As, is that you want to be at your best. You want to be your healthiest. You want to optimize yourself before you go through any sort of fertility treatment, whether it's doing the stimulation or doing the embryo transfer. You know, making sure that you are your best self going into it, because that is the way that you are going to optimize your chances. And whether and using supplements, using acupuncture, using massage, you know, stress relief, meditation, like all of these things, in addition to the medical side of it, you know, making sure your vitamin D level is normal, making sure your thyroid level is normal, all of this kind of stuff, and using supplements to optimize is super important. I can't stress it enough. And if you're not doing any of that, you know, not everyone needs it. I'm going to throw that out there. You know, there are some people that don't need it. If you're not doing it, it doesn't mean that your doctor is doing a bad job, you know, but they should be talking to you about it for sure.
Definitely. And sometimes it strikes me when I go to transfers, the partner says, I wish I had known about this. I would be getting acupuncture as well. And
Yeah.
sometimes people don't know about acupuncture till the day of the transfer. They're basically calling to just have acupuncture during that day. But as you mentioned, it's super helpful if you can do 6 weeks or 8 weeks prior at least. We do recommend that for our patients too. It's kind of like crunch time, right? It's like a pre-game warm up. We need to get everything
Absolutely.
going,
It's like carb
get
loading.
that circulation going, and
Yeah.
you know, we use hypnosis with our patients during acupuncture, fertility meditations, and things like that. So by the time we get to that transfer, it's like, okay, we can do this. We're we're calm and we're ready. So it's similar, I think, to hypnobirthing in labor, right? Women take hypnobirthing classes. They do many things prior to labor, and by the time, I don't know if you guys are familiar with hypnobirthing, basically it's a method to completely relax during contractions. And so it's not that different. The more relaxed the cervix is during the transfer, I think the better for you guys too, when you're doing your procedure.
I will always take a relaxed cervix. Yeah.
Right. And for the comfort of the patient, for sure,
Absolutely.
So,
Absolutely. No, you're 100% right.
Yeah, that's our goal for sure. Okay, we have a few questions here about which causes an SCH?
Subchorionic hematoma.
Oh, okay.
Mm-hmm. Yep. A subchorionic hematoma is sort of like a blood clot that can form when a portion or an area of the pregnancy inside of the uterus separates slightly from the wall. There are certainly some, well-documented things that can cause that if you have like very uncontrolled blood pressure or if there's trauma associated, with the uterus. Cocaine use can do that. Not a lot of our patients are doing cocaine, but very more often than not, we have absolutely no explanation for it. So we do see it commonly in IVF pregnancies. It does not always mean that something is going south, but you do need to make sure that you inform your doctor of any bleeding that you're having. And if they do find a subchorionic hematoma, it's very important that that's another scenario where sex is not an option. You need to go on pelvic rest. No heavy lifting, no exercising, really minimal activity. There's no bed rest, but minimal activity. You also need to address with your doctor if you're taking any blood thinners of any kind. You may be advised to stop those if you have a subchorionic hematoma. And generally it's just sort of a watch and wait kind of scenario. And they'll monitor you usually on a weekly basis to detect the size of it and also your symptoms and whether or not you're having continued bleeding. One important thing about a subchorionic hematoma is that you might experience some bright red bleeding, and then you might go on to continue having some brownish bleeding. And the brownish bleeding is not a new bleed. That's generally old blood. So don't be too scared by that. And just again, communicate with your office and your doctor about any symptoms you're having. And it's not necessarily a bad thing. I've seen lots of pregnancies with subchorionic hematoma go on to do just fine.
Definitely, it resolves usually on its own.
Yes.
Treatment.
It just like reabsorbs, your body reabsorbs it.
Okay, and then the person is asking, I did my frozen transfer 3 months after my second COVID dose. Would this have impacted my transfer success?
So if you did it 3 months after, I think you are well within the recommended range, and I would not anticipate that would have any impact on the success of your transfer. I think that's appropriate.
And someone is asking another question about their FET is at the end of the month, and they just got their second vaccine. Any tests we can do to see if the lining is okay, or should we push it back later?
As I said, if you just got your vaccine, it's mid-month, and you're going ahead with the transfer at the end of the month, that would not necessarily be my recommendation, but you're sort of committed at this point. Again, I think it warrants a conversation with your doctor. Again, every doctor's opinion is going to be different on this. It is certainly and we're between a rock and a hard place, because it is definitely very important for you to be vaccinated when you are pregnant, because certainly when you're pregnant, you are at significantly increased risk for having very adverse complications of COVID. So it's not that I'm not supporting vaccination. I think you should be vaccinated before you're pregnant. I just tend to err a little bit on the more conservative side, and at least educating my patients about the option to wait a little bit longer than that. You should, in preparation for an embryo transfer, you should be having some ultrasounds, maybe weekly, to check on the uterine lining. And so I would anticipate hopefully that you have some of those set up from now until your transfer, to make sure that the lining is adequate. And that may be an opportunity to at least speak with your doctor or, the staff at your office about the choice to proceed. So again, that's just my opinion. There are, you're like I said, you'll ask 3 different doctors and get 3 different answers. So,
and the good news about that frozen embryo it's frozen, right? It's not, you can have time. I mean, I think, unless there's some other pressing need, but that's the good news. It's Absolutely. Not a fresh.
Yeah, no, that frozen embryo is there in perpetuity. So nothing's going to happen to it. Nothing happens to the embryo until the day of the embryo transfer. So there would be no harm in pushing it back, other than, of course, I'm sure everyone who's doing a frozen embryo transfer wants to be pregnant yesterday. Yeah. So.
Yes.
But,
last week,
yeah. 100%.
And I think, that the questions that we had earlier, they're mostly, I think we answered a lot of them, but there's a couple of patients who are not patients, actually, people who have submitted questions who are pregnant currently. And one of them is basically saying, that her HCG level is like 345 at 4 weeks. Do you see like a range that you're comfortable with, for as far as HCG levels? Or
that's a tough one. I'm very conditioned to look at HCG levels after embryo transfer. That's more, and or right after the missed period, which is about 4 weeks. And I think 345 is perfectly healthy. We never know. I think I like to see a level at least above 100. And again, what's more important is not necessarily the number itself, but how the number changes over time. So, it's 345 right now. I would argue that you should check it again 48 hours later to make sure that it has increased by at least 50%. So that tells you that it's more likely to be a healthy pregnancy. So it's really, again, not so much about the number, but how the number changes over time.
And we do have a comment from a partner. It looks like Philip is, unfortunately, his wife did have a miscarriage at 5 weeks with a PGS normal embryo. And he says he's heartbroken as the first transfer worked with a live birth. And my wife thinks she did something to cause this miscarriage. Definitely not, at all. I mean,
no.
I wish that we could give you guys a big hug, but I think, that's not, there's nothing that, and I guess, we as women, we always want to, blame it on ourselves and question ourselves and say, maybe it was because I got up too much, or I bent over and I did the laundry, or did something that caused it. And there's absolutely nothing. I mean, you could talk about this, but I think if it's a strong pregnancy, it's going to hold,
Right. No, for sure. It's devastating, and and I'm so sorry for your loss, and you should take the time to grieve your loss. It's, it's not you'll get over it and just try again. Take the time to have your emotions, and making sure that you're grieving your loss. But it's really important to do the very best that you can to maintain perspective that it's nothing that you did. Taking that walk or picking up that laundry basket, you have to live your life. You have to do things that, I don't know if laundry makes you happy, but maybe walking makes you happy. You have to do things that make you happy, to make sure that your body is there to support the baby. And you can't, blame will get you nowhere, unfortunately. And it's so hard. It's I have not experienced loss myself. But it's so challenging, and, I'm sorry, but just know it wasn't your fault. It wasn't your fault.
and to keep trying. I mean,
Yeah,
you were successful with your first transfer. That's amazing. You know,
that is.
awesome.
Yeah.
Um,
That's the best prognostic sign, meaning
mhm.
to tell me that you can do it again. You can do it again for sure.
And we also had another question about transferring an embryo from another country. Do you guys accept embryos from other countries, or how do you do that?
So it gets a little bit dicey. We have in the past, however, sometimes what happens, number one, it's very expensive as far as I know, because there aren't many companies that can transfer embryos internationally. And number two, we need to make sure that we can accept and appropriately handle that embryo, because sometimes in a different country, the technology and the techniques that they use are different from what we use here. And if you believe it or not, the media that you use, the media or the fluid that you keep the embryo in to help to warm it, to thaw it, if it's different than the media that was used to freeze it, or that was used to grow it, if it's different, that can be catastrophic. And because they're very, very fragile and very sensitive. And so sometimes it comes down to a compatibility issue between the laboratory that made it and the laboratory you want to transfer it to. And that can go for any fertility clinic, even if it's international or not. But I think it happens more often in international clinics just because they tend to use different things than we do. We have done it. It becomes a little bit of like I said, it's just difficult to find a company that can do it, and it can be very pricey, from my understanding.
Good. And diet, does diet have a big impact on embryo transfer?
Absolutely. I mean, if you're eating chocolate cake and McDonald's French fries for forever, then you're not fueling your body with whole nutrients and whole foods. If you splurged and had some French fries, that doesn't mean that your embryo transfer is not going to work. Don't get me wrong.
That's a thing. A lot of people eat French fries after.
They
after
do.
I don't understand that, but
it's a misconception. I think we've also talked about this one too. So usually after an after an egg retrieval, they say that you're supposed to concentrate on salty foods and high protein foods. And certainly McDonald's French fries have that, have the salt covered. Okay.
And many other things. Yeah.
Yes, not so much protein, although maybe a little. And so I think it has been a sort of like a misconception, or like of the truth. But if having McDonald's French fries after your embryo transfer makes you happy, then go ahead and do it. But it's not gonna make or break your embryo transfer. But again, it goes back to being your healthiest and your optimized self before you do an embryo transfer. So just because you didn't follow a specific diet doesn't mean that you're not going to have an embryo transfer, but you need to be healthy. You need to have everything in moderation and make sure you're getting appropriate nutrients from proteins, from fats, from carbohydrates, making sure that you're having enough vegetables and hydration and all of that kind of stuff, because a healthier you means a healthier pregnancy.
Yeah, and the biggest battle is oxidative stress. So if you are, constantly going through trying to get good quality embryos, for instance, what damages the mitochondria, oxidative stress. So the more nutrients we can provide, antioxidants, that's actually going to help reverse some of that damage. But that has to be done for a few months for you to see a difference in egg quality. Because I think one of the questions was, how do I improve my egg quality? Those eggs incubate, just like, they kind of, there's a growth span of three months or so. That they're bathing in that follicular fluid. So CoQ10 and all those supplements that you're taking, it actually enters that follicular fluid in your ovaries where the eggs are growing. And so you have little primordial follicles, those little tiny follicles that are bathing in that. And so, things that we're doing during that span of, let's say, 3 to 6 months, it's influencing those little growing eggs, so usually you ovulate one out every month, but during a stimulation you're getting several of them. So I think that it's important to kind of not load up on antioxidants, but definitely increase them. And that's one of the reasons the Mediterranean diet came out with that, all that research came out in Greece, that the couples that were following that, and they actually did couples. They did not just do the female.
Good.
They actually asked
That's
the men, what they
Yeah.
were eating, and the ones they were eating closer to the Mediterranean diet, they had a 30 to 40% higher take-home baby rate, which I think
incredible.
that didn't even get enough attention. But when I saw that, I was like, well, our patients are going to get some menus.
Yeah.
We're going to get some meal plans, some recipes, some things to cook together, but, and it's not that you have to be super, super strict, but to incorporate that is so important. And that's months and months before the transfer. So I think that's the part that's more crucial.
Yep.
But obviously during the transfer, you want to still continue to eat healthy, right?
Of course. Yeah,
That's
as best you can. You don't need to deprive yourself of anything tasty or treat every now and again is okay. Of course,
chocolate's great with it's high in antioxidants. Dark chocolate,
True.
Magnesium, has all kinds of good stuff. So
yeah, absolutely,
it's a good thing. So
absolutely.
And that's it. So we have a few more minutes left, but we just have like some questions at the end here that we can. Oh, you guys are so awesome. Like, thank you so much for submitting these questions, because we love answering them, I think, and I always learn something. Okay. I've done acupuncture for a year as I've embarked on my IVF journey, and I did a before and after for my FET with Dr. Duro, and now I'm pregnant 14 days after. Yay! Oh, congrats. I'm super happy for you, Laura.
Awesome.
So that makes my day, my week. That's awesome. And come back if you can for pregnancy treatment. We have first trimester nausea vomiting protocol that I think works pretty well. We have I don't think we've seen any patients vomit, and many, since we reopened after the pandemic closure, so last May. So that's exciting. That'll be like my informal study one day on that.
Yeah.
But, it's good. Okay, and as far as the other comments we have about the bleeding, yes. Hey Marlene, that's from Marlene, and this is actually Infant Loss Awareness Month, I believe, and our patient, one of our old patients, Marlene Duruso, she has written a book on her whole journey through IVF, and we actually did a live about that a couple weeks ago. Yeah, so it's on Amazon. So she's on here right now, and it's called the It'll Happen book. Her link, if you guys want to know what she went through. I think it's great that she journaled everything and then, has put it out there and been very open about what she went through. She has a beautiful family now. So thank you for Marlene for commenting.
Awesome.
Okay, and we have another last question about, okay, I don't know how to pronounce this. Is it fluconazole?
Fluconazole.
Okay, there you go. I had no idea. It's 6 days before embryo transfer or frozen embryo. Is it safe?
Fluconazole 6 days before an embryo transfer. I'd probably err on the side of not taking it. I'm wondering why something. I mean, I guess I assume so. Fluconazole is an antifungal, so presumably maybe this individual has a yeast infection, which I guess can be pretty common, especially if you're using, you can have sort of irritation that is related to progesterone suppositories if you are using those. I would I guess I would ask your doctor. I would say that if you have a documented yeast infection, like you went in, you said, I have a problem, we did a culture, we have confirmed yeast, then you should potentially take the fluconazole. But otherwise, if you're sort of self-diagnosing or anything like that, I would not err on the side of, I would not take that 6 days before an embryo transfer. So that's sort of, I don't know, that's my, make sure it's, culture proven, I guess.
And I think we talked about what to eat, what to do before your transfer is just try to rest and relax.
And drink water.
Hydrate, yeah.
To fill your bladder.
Yeah. And, hopefully, I think in general, like afterwards, you're having someone help you, because you guys do recommend rest. Some clinics don't, but I think, resting, there's nothing wrong with that, right?
No, not at all.
Afterwards, yeah.
Yeah, no, like I said, there's, it's not, what I tell my patients is to if they can, to go home and be a couch potato, you know, just sort of, you know, that doesn't mean you can't get up, go to the bathroom, make yourself some food, you know, like all, you know, of course you have to live your life, and a little bit of walking here or there, of course, but you know, I don't want you like deciding to deep clean your house or something like that.
Yeah. Climbing upstairs and everything. Well, at
yeah.
least a few days, I always picture like my patients having a little bell and like ringing their bell, like, okay, bring me this, I'm ready. You know, I'm like, I would totally take advantage of that.
Absolutely, yes. If you want a bell, I will write a note for doctors.
Yeah. Oh, that would be awesome. Okay, so I don't think we're going to be able to get to. Well, we do. We have like a few more. Do you have time to get to the last few?
Yeah, sure. Let's do it.
Okay. Okay. What level does the estrogen and progesterone have to be for transfer?
I like progesterone above 25 or 30, and then estrogen, you know, anywhere somewhere in the 200s, 200 to somewhere in the 200s is where I like to see it.
Okay, that's good. That's transferred a 5AB normal that failed, transferred a 5AA normal, perfect lining on 10-7 in home, test her negative. Doc says my egg quality is likely bad. How can a 5AB and a 5A still have poor egg quality?
That's a tough one. You know, I think I guess my next question would be, are these genetically tested embryos? Because if they are not, then a grade does not always translate to a positive pregnancy test. So, a 5AB and a 5AA are obviously fantastic grade, but you can have an aneuploid embryo or an abnormal embryo that has a beautiful grade. So a poor egg quality tends to have a higher rate of aneuploidy. So I guess to kind of answer the question, presuming that these embryos are not tested, then yes, you can have a beautiful grade embryo, but it can be aneuploid as evidenced, or which is a higher risk when there's poor egg quality.
Yeah, definitely. And it is frustrating, you know, it's like, I think before there was so much genetic testing, some people would say like, wow, the pretty ones aren't the ones that are sticking. It's the ugly ones that look like, you know, they're not that perfect that are sticking, but it's just hard to know. And then, so definitely just keep trying. Yeah. And again, Dr. Bauer, you're amazing. You are, you've been showing up every single month, answering every question. And
my pleasure.
Definitely, I'm excited that you're part of this, and thank you guys for submitting your questions as well. We'll continue our you know, until we answer everybody's questions. Like if you want to submit any questions to us or to get in touch with us, Dr. Bauer, they can reach you at the Boca office, right, in IVFMD. To do consultations. You guys are still doing virtual too, right? Absolutely.
Yep. Okay. I'm in Boca and Jupiter and Vieira. And you can also always DM me. I'm Jessica Bauer _fertility doc on Instagram. So you can always catch me there.
Very cool. And I'm at FL Complete Wellness on Instagram as well, at Florida Complete Wellness. So, you know, feel free to give us a call if you have any questions about acupuncture, anything that you are curious about, and we can help you. So thank you guys. Thank you, Dr. Bauer, so much. It's been fun.
Thank you. All right, let's see if I can figure out how to end it.
Thank you. Good night, everyone. Good night.
Good night.